Blood Bank Guy Essentials, episode 027.
I mean, the classic cases, like HPA-1A cases, those platelet counts are usually in the single digits, like less than 10,000. Sometimes they're maybe 10 or 20,000, but they're not modest, thrombocytopenias. They tend to be fairly severe. And there is usually some kind of bruising or petechiae, things that trigger you to look.
Hi, everyone, and welcome back to the Blood Bank Guy Essentials podcast. I'm so happy that you're here. My name is Joe Chaffin, and I am, as always, your host. I have a really very special guest for you today on the podcast. It's Dr. Brian Curtis, who runs the Platelet and Neutrophil Immunology Lab at Blood Center of Wisconsin in the United States. Brian is an expert on a wide variety of things, including essentially all things platelets, and I've heard him speak on tons of different topics over the years. But I asked him here today to discuss with me something that, in my experience, many people struggle with, and that is neonatal alloimmune thrombocytopenia, or you may know it by its initials, NAIT. In fact, you may know it by different initials like FNAIT or NATP or just NAT. There's a lot of different names, and we'll talk about that just a little bit. But essentially, NAIT is a situation where a baby's platelets just absolutely get hammered by an antibody that comes from the mom. Now, that sounds a whole lot like hemolytic disease of the fetus and newborn if you replace the word platelets in that sentence with red cells. And it really is kind of the platelet version of hemolytic disease of the fetus and newborn. But there are lots of differences, and I think that's where people start to get lost. In fact, another reason that people get lost is that the workup of NAIT actually is usually not easily done in hospital or even blood center reference laboratories. So it's easy to feel out of our depth. But the good news is that Dr. Curtis's lab is a world leader in evaluating NAIT cases, and he is going to take us through today from his perspective what happens, why it happens, what to do about it, and he'll have some thoughts on how we might prevent NAIT in the future. And with that, with full disclosure, Dr. Curtis wanted you to be aware that he has done some research with a company that he's going to mention in Norway that is trying to develop a prophylactic medication to prevent NAIT. Second thing that I would like you to know is that I recorded this interview actually a couple of months ago, but it was delayed, unfortunately, by technical problems on my end. So I am very, very happy to finally be able to give you my discussion with Dr. Brian Curtis. All right, everyone, welcome to the Blood Bank Guy Essentials podcast. I am so honored today to have as my guest Dr. Brian Curtis from Blood Center of Wisconsin. Brian, welcome to the podcast.
Hi, Joe. Thank you for having me.
It is great to have you here. I want to make sure that everyone is aware of some of the excellent work you're doing. So I'd like to tell people a little bit about you. Everyone, Dr. Brian Curtis is the Senior Clinical Lab Director and the Director of the Platelet and Neutrophil Immunology Lab at Blood Center of Wisconsin. Brian has been involved in research, investigations, and clinical laboratory testing of platelet and neutrophil antibodies and antigens for well over 25 years. And the topic that we're going to discuss today is really right in that niche. And I think you're really going to get great value from it. Brian did his undergrad education at Iowa State, his medical technology at University of Iowa, SBB training at Barnes Hospital in St. Louis. And because he felt like he needed a few more degrees, what the heck, he went on and got his master's degree in transfusion medicine at Marquette and his PhD in health sciences and immunology at the University of Wisconsin-Milwaukee. Dr. Curtis has just an extensive background in research and assay development and teaching, and he's done tons of work in platelet and neutrophil autoimmunity, alloimmunity, drug-dependent antibodies, and transfusion-related acute lung injury. In fact, I would consider the laboratory that he runs at Blood Center of Wisconsin to be among the premier laboratories in the world for working up some of these things. And he and I will get into that in just a few minutes and talk about some of that work. He also serves on several national and international committees and has been an invited speaker at numerous national and international meetings. Tons of publications, over 100 scientific journal articles, abstracts, review, and book chapters. And if you've picked up the most recent copy of the AABB Technical Manual, the 18th edition, he wrote the chapter, which is chapter 18, Platelet and Granulocyte Antigens and Antibodies. So, Brian, it sounds like you've been a little busy.
I have. Yeah, it's good busy though.
That's a good thing. You're right. Exactly. One of the things that I always like to start my discussions with my guests with Brian is a lot of the people that listen to my podcast are people that are kind of early in their career, and are trying to figure out, where is their niche? What is it that they want to do with their lives, so to speak? And I guess what I'd love if you could share just a little bit of your story with us. In particular, what was it about transfusion medicine that got you interested and excited, and what is it that keeps you excited now?
Yeah, it's transfusion medicine. I don't always think of myself so much. I think of transfusion medicine of the red cell side more, I guess, because coming up as an SBB and that kind of thing. But I really was not real excited about transfusion medicine, to be honest, when I was young, because I had a bad experience when I worked in a hospital lab where I had to take blood down to an OR and actually issue it, and there were some issues with the paperwork, and I had a surgeon that
Mm-hmm.
wasn't very happy, and I thought, boy, I don't know if I want to do this anymore. That's what pushed me into. I always wanted to do research, but
Sure.
wasn't quite sure how to go about it. And I ended up in research in transfusion medicine, even though I'd had that experience, which was great because, it was um, research is a little more laid back and you get to do things that you can't do in a lab because there's rules and regulations that prevent you from trying things. And I was innovative and curious. And so that research in transfusion medicine was the way to go for me. That's what I was really interested in. I've been interviewed in the past for, how did you get where you are? You sort of took a track that's a little bit unusual. And um, I always talk to people about how when I was a kid, I started out my hometown in the local library. There was a book called How to Be a Scientist, believe it or not. And so I check it out. And I was telling one of our um, people the other day that was asking me about this that my name was on that little card in the front of the book when they used to have those, because I was the only
Sure.
one that checked that book out all the time. And this guy even tried to call my hometown and find out if they still had that book there and see if how many times my name had been in there. But she said that they'd cleared out a lot of old books recently, so it
Uh,
probably got pitched. But I was just interested in science, and I wanted to
yeah.
be a scientist and do experiments, and that's what led me to that. And it just happened to be
Got it.
transfusion medicine
Yeah.
that was the kind of research that I got involved with.
Got it. Today, everyone, Brian and I are going to tackle a subject that I really believe that many trainees and non-trainees struggle with, conceptually and practically. And that topic is well, I'm gonna say this name in quotes because we're gonna get to the fact that everybody calls it different stuff. I'm gonna say neonatal alloimmune thrombocytopenia, but Brian, maybe we should start there because people. I think one of the things that confuses people is that, my goodness, this thing goes by so many different names and people use so many different names. So why don't you start with the name deal and just help clear up some of that terminology confusion for us about different names that people call this disease.
Yeah, so a lot of those acronyms come from what you just said, though. Neonatal alloimmune thrombocytopenia. Some people put fetal in front of that because if you think
Mm-hmm.
about it, this happens when the fetus is in the womb during pregnancy. So
Mm-hmm.
it really technically is fetal or neonatal thrombocytopenia that occurs in these babies that are affected with it. But it goes by NAT, NAIT, NATP. All those are various acronyms that are really based off the same thing, which is neonatal alloimmune thrombocytopenia. So it's the platelet counterpart of hemolytic disease of the newborn, which I think more people are familiar with. It's just the red cell version where mother makes antibodies against the fetal red cells in that case, and it's usually the Rh antigen or D antigen in that, and in thrombocytopenia, neonatal alloimmune thrombocytopenia, it can be any of the different platelet-specific antigens, but the one that's by far the most commonly seen is antibodies to HPA-1A, which used to be called PLA1. Sometimes in textbooks you'll still see it called that, but that was the first antigen. Antibodies to that antigen were the first ones ever discovered, and um, in Caucasian populations especially, you see a lot of the NAIT due to that antibodies to that antigen.
Okay. Well, why don't we just start from the bare beginning, and let's so I love the analogy, and obviously there are some differences that we'll talk about in just a minute with hemolytic disease of the fetus and newborn with red cells, but just if you would just kind of take us from the beginning and describe, if you will, how this occurs. What's the basic sequence of events that leads to this?
Okay. So to start with, there has to be an incompatibility between the mother and the father of the infant. So for usually one of the platelet-specific antigens, and so I think we're up to around 35 different platelet alloantigens that have been discovered to date. The first five, HPA1, HPA2, HPA3, HPA4, HPA5, all of these are biallelic systems. So they have an A allele, which is the high frequency allele, and a B allele, which is the low frequency allele. And those frequencies can sometimes differ between different ethnic groups or populations, but these are all SNPs by and large. So single nucleotide polymorphisms, one base change in the DNA that then encodes a change in the amino acid in the protein. And so then if you have one or the other of those, if you're homozygous for it and you get exposed to the opposite antigen, then you can make antibodies against it. So let's just stick with HPA1 since that's the one we deal with the most often. And so in the classic example of probably 85% of neonatal alloimmune thrombocytopenia, the mother's HPA1BB, homozygous for the B antigen, that's only 2% of the population. And then the father's HPA1A positive, so either heterozygous 1A, 1B, or homozygous 1A, 1A. And so when they conceive a child and that 1A antigen gets passed on to the fetus, then during pregnancy, if mother gets exposed to that antigen in some way, typically we would think that it's platelets from the baby that get into maternal blood and she gets immunized, then she can make antibodies, and those antibodies, IgG antibodies, can cross the placenta during pregnancy, get into the baby's bloodstream, bind to the baby's HPA1A positive platelets and destroy them or clear them from circulation in the liver and spleen, etc. And if you get a infant that's got low platelets or thrombocytopenic, then that infant's going to be at great risk for potentially severe bleeding as a result. And we're mostly worried about the bleeding that might occur in the brain, which we call an intracranial hemorrhage, especially after birth, because during the birthing process, it's somewhat traumatic. The baby's passing through the birth canal. There's a lot of pressure on the head, and the babies are fragile, and you can get then hemorrhages because of that. And the vast majority of these cases still to this day, because we have no screening for this. We don't screen all pregnant women for HPA1A like we do for the D antigen. So we don't know that there's this incompatibility, and all these cases are discovered in the first pregnancy when there's a baby that's born with bruising and petechiae, which are small little bruises all over the body and potentially bleeding. And then they say, hey, what's going on? And they do a blood count, CBC, and find out that the platelet count's low.
Right.
And that's what then triggers a physician to say, I wonder if this is NAIT, and they then go and try to get a workup for platelet antibodies in the mother.
Right. Okay. With the classic forms of hemolytic disease of the fetus and newborn, we think of it as a baby, a D positive baby is born to a D negative mom. At the time of childbirth, usually mom is immunized. She makes the antibodies, and future pregnancies are at significant risk. My understanding with NAIT is that that's not necessarily true. That in some cases, first pregnancies can be at risk as well. Is that correct?
Yep, that's a good point. So that's exactly right what you just said. You see, you don't see first pregnancies in HDN affected very often, if at all, but in NAIT, we do see first pregnancies affected. So there's been some controversy about the frequency of that. For many years, you'd read reports and reviews, and even I wrote some of these, and we would say as many as 60% of first pregnancies can be affected. I just wrote a review article recently for British Journal Hematology on an update to where we're at with NAIT and the pathogenesis, and realized is that really true? And I went back and talked to some of the people that originally put that data out there and talked to some of the groups that have looked at it more recently. Probably some of the best data on that that's come out recently is from the Norwegian group. They've studied thousands of now women that have been pregnant, and they've typed them. They focused in on HPA1 again because that's more common, and they followed those pregnancies through. And their data shows on large numbers of pregnancies that they followed that it's probably about 10% of first pregnancies that are affected, somewhere around there, so lower than we've said over the years. If you talk to some of the high risk OB groups that get patients, their numbers are more like 50 or 60% of first pregnancies. And I think what I wrote in that article is the discrepancy is in those big studies, they have a huge N. And so you divide their numbers by that huge N and you get a smaller percentage of the first pregnancies. In these high risk OB groups, they typically are only seeing the very severely affected children. That's why they're brought to their attention. And so their ends are smaller, and and so then it looks like they're seeing more first pregnancies affected, but probably the 10% numbers closer to reality as far as overall how often we see this. I think another important point is that just because a woman, as the example we used, is HPA1BB and she's exposed to an HPA1A positive fetus, only 10% of those women go on to develop antibody. And there's some things we know about what makes you more vulnerable to making antibody or not. And so I have a lot of discussions with physicians because some of them say, hey, if this happens, if this sequence of events takes place, it's the baby's going to be affected, but not always. And so a lot of times we'll just screen the mother during a first pregnancy if this comes to our attention for some reason, and look to see if she makes antibody before we'd ever start to treat her.
Right. And that brings me actually to the second point that I wanted to make sure that we talked about with hemolytic disease of the fetus and newborn. The process of screening and prevention is extremely well defined, whereas with NAIT, we're talking about something, from my perspective anyway, and please correct me if you have a different perspective, that's much more, we seem to be much more reactive with this, rather than jumping on and going, hey, look, this mom is at risk, let's give her this drug to prevent HDFN, or in that case, or NAIT from occurring. That process is not something that's currently going on. I know there's some discussions about that in the future, but is that a correct perspective, Brian?
That's right. So there's been a lot of debate about whether we should, should we screen all pregnant women for HPA1A is the one that's been suggested most because, again, it's the most one we deal with most often and most frequent.
Mm-hmm.
And some people think we should, and some people don't. I think what's held us up over the years from not doing it, it started off with the testing wasn't so good for typing. Not that long ago, back in the early 90s, we were still typing using serologic reagents mostly. And you can't buy those like you can even for red cell typing. We had to just take good antibodies from patients that we'd seen and try to take the best ones, maybe sometimes absorb HLA antibody reactivity and things out to make them better for typing. And that just wasn't going to work for large scale screening of women in that setting. And so then genotyping took hold, and that was really because of a guy that still works for us out at our research institute, Peter Newman, was able to characterize the HPA1 antigen polymorphism. That was the first time that had ever been done. So now we had the ability to genotype for these platelet-specific antigens, and that made it possible. But in the beginning, it was very expensive and it was labor-intensive, so it was never real conducive to high throughput screening of lots of women. So it sort of was, those were always the excuses. Now those can't be excuses. We have very high throughput ways of typing women. Probably genotyping would be one of the better ways to go.
Okay.
But there have been some monoclonal antibodies to HPA1A that have been developed you can use in typing in like ELISAs or flow cytometry that potentially could be used too. I think what the holdup is now is, what the second holdup always was, is we never had a treatment or a prophylaxis.
Right.
And so today we still don't have a prophylaxis. We have Rh immune globulin for HDM, but we don't have any similar product for NAIT.
Mm-hmm.
So uh, there's we can talk later about how do we treat a next pregnancy in somebody, mother that's had this, had an infected child. But right now there is a company that's trying to develop a prophylactic reagent. The name of the company is Profilix,
Mm-hmm.
and they're in Norway, and they're trying to make very similarly to how Rh immune globulin is made. They want to make an HPA-1a immune prophylaxis to give women to prevent NAIT.
Mm-hmm.
And I think once maybe that's in place, now we have the ability to screen women for the antigen. We have ability to treat them with something that will hopefully be effective.
Mm-hmm.
And then it comes down to, will physicians do it and will insurance companies pay for it?
Right.
Unfortunately, in the US,
Yeah.
we have that issue.
Yep.
Whereas maybe in Europe, they'll adopt it sooner. It's hard to say. But then there wouldn't be any reasons not to do that, because we'd have those problems that existed in the past solved.
Mm-hmm. Mm-hmm. Okay. A couple things just before we move on. If you said this, I missed it. Is there a rough estimate for how often NAIT occurs in, like, one per whatever number of live births?
I never did say. Depends on the studies, and people debate this a little bit too, but the vast majority of groups that study this disorder will agree that it's somewhere around 1 in 800 or 1 in 1,000
Okay.
pregnancies is affected with NAIT.
Wow.
And that data is primarily comes from the HPA-1a cases that have been studied. So maybe it's a little more frequent, not a lot, but just a little more. Maybe that's where the 1 in 800 number comes from, because there are some other antigens that you can be couples can be incompatible for, that antibodies are made against also, that can do this. They're just much less frequent. But you put that together with HPA-1a, and it's a little more frequent because of that.
Okay. Well, so I think we've established pretty clearly that we've got a disease that we have a pretty good idea of the why, for the most part. Obviously, there's still some things to be worked out, and some different associations and all that, but we kind of have a general idea of the pathophysiology and the incidence, and the fact that it is potentially a very serious deal. Obviously, intracranial hemorrhage in a fetus or a newborn is a potentially catastrophic event. So why don't we shift gears a little bit, and let's talk about, once one of these is diagnosed, or once one of these is, let's not say diagnosed, let's say suspected. So someone's working in hospital world, and they have a baby who has a low platelet count, with or without intracranial hemorrhage. This is where I want to tap into your incredible expertise with this, Brian. What are the things that they should be looking at? What can be done locally, and what should be sent to potentially a lab like yours or yours?
Okay, so like you said, that you'll have a thrombocytopenic child born. I mean, the classic cases, like HPA-1a cases, those platelet counts are usually in the single digits, like less than 10,000. Sometimes they're maybe 10 or 20,000, but they're not modest, thrombocytopenias. They tend to be fairly
Mm-hmm.
severe. And there is usually some kind of bruising or petechiae, things that trigger you to
Mm-hmm.
look. And then, of course, is there an intracranial hemorrhage or not? That's important to look at for, no matter what, in those settings, just to make sure that if it happened, then you want to know that, and act on it if you need to. And then treat the child for the thrombocytopenia if you need to. Most of the time, the antibodies clear out of their system, and their platelet counts will come back on their own, and they don't need any platelet transfusions or IVIG, things that might be given. But sometimes they do, especially if they have bleeding, and so we always ask our SBB students, what platelets would you give the child? And there's some different options. The obvious best choice, if they're available, would be a platelet you have on the shelf that's ABO compatible with the child and is HPA-1BB, so that the mother's antibodies don't continue to destroy those platelets when they're transfused. Another option is that some people don't think about, is to use the mother's platelets. And I've seen mothers, that had apheresis after delivery, and they use their platelets. The real key there is, and you'd think it's so obvious that would never happen, but I've seen it happen multiple times, is you have to wash the mother's platelets, because there's all that antibody in there, and you don't want to be transfusing HPA-1 antibody back into the fetus. And I've seen a case where a physician couldn't understand why the fetal platelet count hadn't come up for 6 weeks. And I asked what he was transfusion. He said, mother's platelets. I said, did you wash them? And there was a long pause on the phone. And then he said no and hung up. And that was the last I heard him. So I obviously realized he had made a mistake. It was interesting because that person called me back later and gave a transfusion and showed that the count was fine. And so we kind of proved it in that sense because they washed the next transfusion.
Yeah, that's kind of the classic standardized exam question from the past of the perfect platelet product for a baby with fetal neonatal alloimmune thrombocytopenia. I can't talk, for NAIT. Let's just put it that way.
And then I think this is really important to just the other options. If you have anybody that's bleeding and need platelets, you don't have time a lot of times to find a compatible one or cross match somebody or whatever. So they would just give random platelets, and those will do okay. They may not survive as well because the chances are they will be HPA-1a positive, 98% chance if you pull a random unit off the shelf. But they'll help the child with the bleeding, and you need to give that platelet, so you should. And that's actually been documented in the literature. I mean, everybody knows this that deals with these cases, but it's actually also been in a blood paper several years ago, just to show you that you're not going to hurt the child by doing that. It's just you might have to give more frequent transfusions until you can find a compatible platelet. And some people even believe that by giving the incompatible platelets, you actually absorb the antibody and hasten their recovery by removing the HPA-1 antibody from their system faster. Whether that's true, who knows? But there's some people that think that's a possibility. So that maybe that's a good thing in that sense to give them incompatible. But I've least in the cases that we've been associated with, never seen an infant injured by giving them a HPA-1a positive platelet that's random. A lot of that mentality too comes from our red cell blood banking training and things. You don't give incompatible blood to people because you could theoretically kill them, but we give incompatible platelets to people on a daily basis, and we don't kill them. We just don't maybe do a very good job of increasing their platelet count if they're incompatible. But I mean, incompatible platelets to this day are still given to people by the boatload. So I think that's where maybe some physicians get a little spooked by not wanting to do that.
So let's talk a little bit about, I'm desperately wanting to get to the specifics of the workup that you do. But before we do that, I think there's one more thing that I'd like to just, because I have you here and your expertise is so vast. There's one thing that I know that students get confused about, and that's you've talked very in wonderful detail here about the HPA antigens, the human platelet antigens. I think that students in particular and people that are new to the field struggle with what kind of stuff is on the surface of a platelet. I mean, I think we have this tendency to think of platelets as these just little fun bags of thrombotic activity, but they're really complex on their surface, and there's obviously more antigens on the surface of a platelet than just these HPAs. Could you just briefly, because I want to get to the workup, can you talk to us a little bit about other stuff that's on the surface of the platelet that could cause a problem and potentially an incompatibility?
Okay, so the most obvious thing is class 1 HLA, which is on most cells and it's on platelets. There's been studies done that show that technically platelets are the carriers of the majority of class 1 HLA in the bloodstream, actually. Now, lymphocytes have probably more HLA per cell on their surface, but platelets, there's so many of them that the vast majority of the HLA in the bloodstream comes from platelets. That's certainly immunogenic. Most patients, we're getting a little off subject, but patients that develop platelet refractoriness, it's a huge issue. You'll hear about it all the time. People trying to figure out how can we give better platelets or more compatible platelets to people. The majority of those refractory cases are due to HLA antibodies that cause platelet destruction. Autoantibodies we just talked about a little bit ago, but there's people that develop antibodies against their own platelets. Still, people refer to that disorder as ITP, autoimmune thrombocytopenia. Those but those antibodies tend to target some of the glycoproteins that are specific to platelets, like 2B3A is the big one, and then GP1B9 is another protein. And those proteins are, of course, very important in how these platelets function, and they just happen to be immunogenic as well if you get exposed to an platelet that's the opposite alloantigen type that you have. But then there's, you know, some of the major glycoproteins that we deal with on a regular basis with alloimmune thrombocytopenia. As we mentioned, 2B3A, the HPA1 antigen is carried on 3A. A lot of the other HPA specific antigens are carried on the 2B or the 3A protein. There's some on GP1B9, which is a receptor for von Willebrand factor and platelet adhesion to damaged endothelium. 2B3A is the fibrinogen receptor that's involved in fibrinogen cross-linking platelets and forming the platelet plug. So that's its value. The collagen receptor, GP1A2A, the GP1A protein carries the HPA5 antigens, which are probably second to HPA1 in causing some of the alloimmune disorders like NAIT. There's a protein called glycoprotein 4 or CD36 that is on the platelet surface. The only blood cells that express it are platelets and monocytes, interestingly enough. And there are some groups, some populations, specifically Asians, so Chinese, Japanese, Koreans, and even Asian Indian groups probably, and African people of African ancestry, so African Americans or Native Africans. There's about 3 to 5% of people in those populations that have no GP4 in their platelets at all, zero. And yet their platelet functions just fine. But if one of those individuals gets exposed to glycoprotein 4 through pregnancy or transfusion, they can make antibodies to GP4. And so those are some of the other proteins and antigens that are expressed on platelets. There's obviously lots of other receptors and things that allow platelets to function, that allow them to interact with other cells and do what they do. Oh, and I don't want to forget about ABO antigens on platelets. So there's A and B antigens, and if you're group O, of course, H. And you can detect those antibodies reacting with platelets just like you can with red cells. There's much less ABO on platelet surface than there is on a red cell. But there are times where you can implicate antibodies to ABO in some of the platelet disorders. We've even seen a case of neonatal alloimmune thrombocytopenia that involved the B antigen. Mother had very high titer anti-A comma B that caused NAIT. I'm almost certain of it. And so those things are there. We have to take that into account when we do our testing that we're going to talk about in a minute, just like red blood cell labs have to, in that we use O platelets primarily so that we're not seeing the ABO reactivity, because in general it interferes with detecting the platelet specific antibodies. That's what we're really interested in our work. And then of course HLA, those antibodies are pretty ubiquitous, especially in women that have had pregnancies, and we have to do things, special tests to try to exclude those so that we know we're only detecting platelet-specific antibodies.
Okay. Well, that makes sense. I think that's a really great overview, and I led you a little bit down a tangent. You're right about that. So let's get back to where we were headed, which is, so you're in your laboratory and you have a potential case of NAIT that you're trying to work up. What are the things that you look for? What are the things that you test? And just take us through generally how this process works.
Okay. So what I think is the ideal workup to make sure that I've done a thorough workup is and this has been established pretty much, there's groups like our lab in pretty much every country around the world, and we get together on a regular basis. That's called the International Platelet Immunology Workshop, and we share samples back and forth, and we try to improve what we're doing in the laboratories. And these are some of the big reference labs from each country. So there's labs in the UK and in Germany and France and China and South America, Canada. And what we've established from that is to do a thorough workup for neonatal alloimmune thrombocytopenia. We like to have genotyping of the mother and father. for some of the antigens that are most frequently involved. So most labs would genotype the parents for both HPA 1 through 5, 6, 9, and 15. Those tend to be the antigens we see most often implicated. And we look for incompatibilities between the parents in those. We're almost certainly going to find some because some of those antigens are very frequent. And if you took a couple off the street and typed them, they would certainly be incompatible. That doesn't mean they're going to have a child with NAIT, but it's a tool that helps us. And then we look for antibodies in maternal serum that are specific for one of those antigen incompatibilities that we saw in the parents. If we have that, then we'd say we have a serologic diagnosis of NAIT, and we would tell the physician that in the report. The serology consists of various tests. Some labs use different ones. The classic tests for many years were one was called the MAPA, which stands for monoclonal antibody immobilization of platelet antigens, MAIPA. That was discovered in Germany in the mid-80s. And we discovered and developed a test here at the Blood Center of Wisconsin around the same time, and we called it the MACE, or Modified Antigen Capture ELISA, MACE. These tests, the basis of them, they're very similar tests. There's only minor differences between them other than where they were developed. And they consist of capturing a monoclonal antibody that's specific for the glycoprotein on the platelet that carries the antigen that you're interested in looking for antibodies against. So you can capture on a plate or on a bead or any solid support the antigen from a lysate of platelets that you know the genotype of, and then when you add the patient's serum and do the incubation and look for antibody, if it lights up, knowing the phenotype of that platelet, you can get some idea of what the antigen that antibody recognizes. And so we'll capture the various glycoproteins that I mentioned previously that are on platelets with these monoclonal antibodies and look for this reactivity. And that's how we look for antibodies in mother. We look in the mother because the mother made the antibody, and she's much more likely to have a stronger level of it or a higher titer such that we can detect it. Some physicians ask, why don't you test the baby because they got thrombocytopenia and they're the patient. And we've tested some children, but my experience with that is even if mom has a very strong, say, HPA-1A, many times we can't detect that antibody in the baby, or it's much weaker and it's harder to get the specificity in the child. So we don't bother much with testing the child. And then based on dad, the other important part about typing the father, genotyping him, is now we've resolved if we have that NAIT has occurred and it's because of this antigen that we showed there's antibodies in mother's serum against. Now what's going to happen in the next pregnancy? What can we do to help prevent this in the next pregnancy? And one thing we can do is, based on dad's genotype, we can determine if the next baby will be affected. So if dad's homozygous for the antigen, then we know all the babies are going to be heterozygous. They're obligate heterozygotes, and they'll all be affected. And so in that case, there's treatments that can be given to the mother to try and prevent this baby from getting thrombocytopenia in the next pregnancy. We can talk about what that is if we have time. The other, if the father is heterozygous, then there's a 50-50 chance the next baby will inherit the antigen. And so if that's the case, what we can do, or what we do now, is we get an amniocentesis sample from the mother at a certain time point, and we with DNA type the fetus to see if it inherited the antigen. If it didn't inherit the antigen, we're done. We don't need to do anything. No treatments, just normal pregnancy. But if the baby inherited the antigen, then we need to start the treatments that I mentioned before. But that's typically how we do it now. The big push right now from physicians, I just had a discussion with some at the American Society of Hematology meeting recently, is they want to not do an amniocentesis. They'd like to get fetal DNA from maternal plasma. There you only have to draw the mother's blood sample. And we would like to do that too. The problem with that is several years ago, when that process was available, we did have a test, but we were stopped from doing it because there's a company that owns a patent on it, and they were pretty strict with the requirements about licensing that patent. Some labs in the US especially weren't able to do it, unfortunately. Now that patent's expiring, and so we're trying to bring that testing up. But it's obvious as to why that's a preferred way to go, because you don't have to punch a needle in a woman's abdomen and get amniotic fluid to do the typing. So hopefully we'll be able to do that less invasive in the future.
All right, Brian. So let's come back to the practical aspect of this. So let's say you have a scenario like you described where you've done mom and dad's genotyping and you see that there's an incompatibility there in their HPA genetics, and you screen mom for antibodies. She's got an antibody against something that dad is carrying, and you've either found that dad is homozygous there, or that dad's heterozygous, and you've, through the other work that you described, that you've discovered that the baby is at risk. So what happens then? What are the next steps that people taking care of this baby might do?
Yeah. So there's a lot of different options that mothers, of course, can take, and they'll talk to genetic counselors and their physician and preconception counseling to decide what they want to do. We don't want to get into all of those things because there's a lot of different options. You get a sperm donor that matches mom's antigens, and that's a lot of work and expense. But I just want people to know there are other things besides what I'm going to address, which is IVIG treatments. And so the what we'll do for a mother in that situation that you just described is she'll get IVIG at a certain dose, usually with steroids, that might be escalated. The doses might be increased at certain time in the pregnancy, depending. A lot of it's dependent on how severely affected the first child was, as far as intracranial hemorrhage and degree of thrombocytopenia. And again, there's protocols that are published for this, but mom gets the IVIG weekly. She has to come in. She has to sit and have it infused. Might take a couple hours. There are some side effects. Some women don't tolerate it very well, and they get headaches and things. And the cost, of course, is a big issue. It's expensive. IVIG somewhere around $5,000 a dose, and if you have to do this, we usually start around 12 to 18 weeks and carry it throughout the pregnancy each week, so that can get very expensive. But it's very effective. The protocols, it took a while to work those out. There's a physician in New York, Jim Bissell, that worked a lot of these out many years ago in some of the trials. But it's effective. The babies then typically are born. They don't have thrombocytopenia. If they do, it's mild and there's not bleeding, and they can get through the pregnancy without being affected. So it's a effective treatment, and that's how we handle it. I mentioned before there's this company, Profilix, that's trying to develop a prophylactic product similar to Rh immune globulin. So hopefully when that's out, we can actually prevent it rather than have to go through these IVIG treatments.
Ultimately, that would be great. There's, as we close our time together, Brian, I know that there is. I'm certain that if we were sitting having a drink somewhere, you could probably go for a couple more hours with all the cool stuff that you're working on and all the amazing research that's out there, and all the stuff that you and your lab are considering and actively already in process of. But since we're about out of time, I just want to hit you with one last question that's really practical. And let's imagine a scenario where we've got a baby who's thrombocytopenic, and that we've sent all the appropriate workup to you, and your lab has done all the work, and you found, okay, the workup is completely negative for those HPA antibodies, and maybe you found something like an HLA, which we didn't really talk about in great detail, but my understanding is not clearly associated with neonatal alloimmune thrombocytopenia at this point. But let's just say that that's all you have, or that there's nothing. Well, what are the next steps? You still got a baby who's thrombocytopenic. What kind of stuff when people have that conversation with you, what kind of advice do you give them?
Yeah, that's a great question, because I get that question a lot from physicians that call either before they get results or they've gotten the results and they have the scenario you mentioned. It's important, like you said, talk about HLA quick, is that it's real hard to implicate HLA antibodies in NAIT. That's a big controversy in the field that all the labs struggle with. And one of the big reasons is so many women make HLA antibodies, but we don't see that rate of NAIT in pregnancies. So obviously HLA antibodies are a rare cause, but maybe they do, but we don't have any way to distinguish, quote, the bad from the good HLA antibodies. So what we typically, or what I tell people is, we follow what we call this algorithm. I'd be glad to provide it to listeners if they are interested. It was published in Obstetrics and Gynecology back in 2011, and the it follows this algorithm of checking moms serially for antibody screens for platelet specific antibodies approximately once each trimester. We usually like to do the first one at 12 weeks of gestation, then at 24 weeks, where we include a cross match with the father, and that's to catch low frequency antigens. That's the only way to catch those, is to have father's platelets cross match with mother. And that's a very important part of the workups too, that we didn't talk a lot about when we talked about the workup. That's the only way to catch those low frequency antigens. And then we do it again at 32 weeks. So 12 weeks, 24 weeks, 32 weeks. If we don't see any platelet specific antibodies, all we see is HLA or something like that, then we don't do anything. But if there is an antibody that pops up, say an HPA2B, for instance, then you could start the IVIG treatment protocols at that time. That way you prevent somebody from empirically getting IVIG because of the reasons we don't want to do that if we don't have to. And a lot of those cases, we don't see antibody throughout the pregnancy, but it makes the mother and it makes the physicians feel good because we're doing something, we're looking, it's not invasive, it's not real expensive. And in my experience, at least, it's effective. So that's what we do in those kind of cases.
Let me ask you this, Brian. I promised that was the last question, but I lied. When you do you have a rough estimate? And I think you guys have published this in a paper back in 2004, but I don't know if you have any update of the cases that you get sent. Do you have an idea of the rough proportion of those that actually that you go through and you confirm? Yeah, there's an HPA antibody, and dad is incompatible. Do you have a rough idea of those numbers? That's a good question.
Yeah, we do have those. We use it all the time to sort of gauge how well we're doing with our testing and try, if we make improvements, are they effective? We probably to this day, it's still about the same. Of all the cases that come through, about a third of them, 30%, we find an antibody and it matches an incompatibility between the parents, and we have a serologic diagnosis of NAIT. About another third, we find no antibodies. And we used to worry those are the ones we're missing. Maybe we need to beef up our test. But I think now, with the long years of experience we have, I think a lot of those are probably not NAIT. If you look at the clinical histories, we get follow-up from the physicians. A lot of times, these are things like fetal brain abnormalities that are noticed on ultrasound during the pregnancy. And there's probably some other cause for that. And the doctor's just being safe to try to rule out NAIT. So I'd say a majority of those, that third is that. And then the final third is we'll get positive serology, but for something that's not a platelet-specific antibody, so HLA or ABO or something like that maybe could cause it, but you can't really prove it. And those are the ones, that we try to work on and say, is there more we could do there to look for something else? So to really answer your question, it's about 30% of the ones that come in that we actually get that match, and we find that platelet-specific antibody in mom's serum.
That's great, Brian. Thank you for helping us to understand that. I think that this episode has really been helpful because it's so misunderstood. Neonatal alloimmune thrombocytopenia. Not only is it hard to say, which I've stumbled over like 4 or 5 times, but I think there's a lot of confusion about it. And I really think you've helped clear that up, not only from the laboratory perspective, but a little bit from the clinical perspective as well. So again, thank you so much for being on the podcast.
Okay, well, thanks, Joe, for having me on. I enjoyed it, and I hope it was useful, and that your listeners find it to be helpful to them and better understanding NAIT. Thanks again.
Well, I hope that Dr. Curtis helped to clear away some of the mystery surrounding NAIT in your head. Honestly, I'm just so honored that he would take the time to teach all of us about it. Because the reality is, if you're hanging around transfusion services or blood centers, you really need to get NAIT. You need to understand it. You will be confronted with it at some point, and you really need to know what to do. So my thanks to Dr. Curtis, both for appearing on the podcast and for his patience while I worked out some bugs from the interview, technical challenges, as I mentioned before. My thanks to all of you. You have all made this podcast far more successful than I ever dreamed it could be. We've had over 35,000 downloads in the past 9 months. Honestly, I just love helping you learn the essentials of blood banking and transfusion medicine, and I would love to keep doing that for you. So if you would, if you're listening to this on your phone, not if you're driving, but if you're listening to this on your phone or on a computer, just head over to bbguy.org/subscribe and get on my email list so that you won't miss any of the cool stuff that I have coming for you. There's a lot of great stuff coming in the next couple of months. Also, the next time you are on a computer, just head on over to iTunes and give this podcast a rating and a review. It's pretty simple to do. Just pop open iTunes, type in Blood Bank Guy Essentials Podcast, and my page will come up. Just give me a rating and a review if you don't mind, because it really helps others see it and learn from the podcast too. So that is it for today. I really want to thank you one more time. And as we close, I hope that as you go through your day, that you'll smile and that you'll have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.